Good morning, everyone. It's 9 o'clock, and I'd like to welcome you all to MCHP's Annual Evidence to Action Workshop. And welcome to this first webinar of the workshop on the health status and access to healthcare by registered First Nation peoples in Manitoba. Because we're gathering today virtually, we're in different parts of Manitoba and beyond. Please acknowledge that the homes and workplaces that we're joining from are located on traditional lands of Indigenous peoples. A number of the speakers and facilitators are wearing orange shirts for Orange Shirt Day tomorrow, which started as a way to educate and promote awareness about the residential school system and its devastating impact on Indigenous communities across Canada. We not only acknowledge this and other harms and mistakes of the past, but the ongoing colonialism and structural racism that continue to cause harm today. And we commit ourselves to work in partnership with Indigenous communities to disrupt systemic racism and colonialism. A couple of things to note about today's webinar. We're using WebEx today, which allows you to see and hear the panelists for this session, but you as the audience cannot be seen or heard. This presentation will be about 45 minutes with some time for questions afterwards, which we'll conduct by using the chat function, which is at the bottom right of your screen. We ask you to use the chat function only for questions to the speakers about their presentation or to flag technical issues like advancing slides. Feel free to post your questions as they occur to you. After the question and answer session, there'll be a 15-minute break before the next session, which begins at 10:15. After the break, please log into the concurrent session that you registered for by 10:15 by using the link in your welcome email. And now I'd like to introduce the speakers for our morning session. Dr. Alan Katz is the director of the Manitoba Centre for Health Policy and a professor in the Departments of Community Health Sciences and Family Medicine. His research focuses on primary care delivery, including quality of care indicators, knowledge translation, and disease prevention. Leona Starr is a Cree woman from Thunderchild First Nation, Saskatchewan, within Treaty 6 territory. She is the Director of Research for the First Nations Health and Social Secretariat of Manitoba. She has worked collaboratively locally, regionally, and nationally to ensure research and information is governed according to principles and protocols defined by First Nations. Take it away, Alan and Leona.
Thanks, Marnie. Good morning, everyone. And on behalf of the Centre, I want to thank Leona for doing the presentation today. She's, I think, doing 3 presentations today, so a key part of our Evidence to Action Day. It's very important for us at MCHP to have this partnership with the First Nations Health and Social Secretariat. And Leona has been a wonderful partner with us, as have other members of FNHSSM over the last number of years. We have the honor today of presenting the findings of the deliverable that was completed in 2019 around the health status and access to healthcare by registered First Nations peoples in Manitoba. One of the reasons for presenting this work is that we've got a long way to go, and the results are somewhat concerning when we look at the health of First Nations people in Manitoba. So I'm going to try and advance the slides, but suspect that my thing is not working. So I'm going to ask that we move to the next slide. And somebody else will jump in. There we go. Thank you. So this is the team that worked on this deliverable over a number of years. And as you can see, it's a lot of work. It's a lot of people. Yes, it was a lot of work too. But I just want to acknowledge that the work we do at MCHP is generally done as a team. And this is a classic example of a large team of people that work together to put together this report. We also had an advisory group of many of the health technicians at multiple communities who supported this work. So Leona's going to go on to the next slide.
Thank you for that introduction. I just want to introduce myself. That's it. Good morning, everybody. Thank you for that introduction, Alan and Marnie. Just to give you a bit of background in terms of who we are as partners. I currently work as the Director of Research within the First Nations Health and Social Secretariat of Manitoba. also referred to as FNHSSM. Our entity was formally established by Chiefs in Assembly back in 2014. And when I say Chiefs in Assembly, I really refer to the Assembly of Manitoba Chiefs, who've also upheld, I guess, governance and oversight over First Nations information and data as applied by, as ensured by the Health Information Research Governance Committee, which I'll explain a bit more about in the following slides. As we all know, as First Nations, we've often been excluded from First Nation or research that pertains to First Nations, and it's always come from a lens or a worldview that has not been our own. So in terms of honoring the voices of First Nations, the partnership, this ongoing partnership between First Nations within Manitoba and the Manitoba Centre for Health Policy, we've had a long-standing relationship where we've agreed to come together to really showcase and tell our own stories from our own perspective. In 2002, we partnered on the very first First Nations Atlas under the leadership of Dr. Pat Martins, the late Dr. Pat Martins. And based on that relationship, excuse me, we've entered into a new era of reconciliation. Since 2002, we now have the Truth and Reconciliation report that was endorsed by leadership and calls to action that have been put out to all of us, not just institutions, but us as individuals. And since that time, we've actually come into a place of a relationship that is governed by information sharing agreements, and the importance of information sharing agreements between First Nations and entities like the Manitoba Centre for Health Policy, which kind of outlines how we relate to one another, how we assert governance over information, how we work together to showcase some of our results according to our own lens and worldview. Next slide, please. So as I alluded to earlier, we have had a long-standing oversight and governance over information and research within Manitoba. We have one of the longest-standing First Nations ethics boards called the Health Information Research Governance Committee that was established back in the 1990s. And that governance committee still governs and provides that oversight to First Nations information, data and research as it applies to us today and as we continue to establish these long-standing relationships. So across Canada, we have had various partnerships as FNHSSM, as the research team of FNHSSM, and have long provided that support to the Health Information Research Governance Committee, and also in support and reaffirming our rights as Indigenous people, as outlined within the United Nations Declaration on the Rights of Indigenous People, and also seen within the Constitution Act, where treaty and Aboriginal rights are recognized and affirmed. And this is the place that we come from in terms of providing that context and why it's important to create space for First Nations voices, especially when it applies to research that is about us. So in looking forward in terms of our relationship with Manitoba Centre and members like Dr. Alan Katz, Dr. Mariette Chartier, Dr. Chelsea Ruth, whom we've all partnered with to really deliver the evidence needed for us as First Nations to make informed decisions around planning and preparedness, and really showcasing, I guess, the disparities that we know exist given our different fields. So next, please. Oh, I guess we're having technical difficulties. There we go. I'll hand it over back to Alan.
Thanks, Leona. Yeah, unfortunately, the slide transitions are not smooth, but we'll overcome those challenges. We're not new to overcoming challenges in the work that we do. As with all of the work that we do at the Manitoba Centre, we tend to use the Manitoba Population Research Data Repository as our data resource and sources for the analyses that we do. The schematic on the screen is something we've used for quite some time now to demonstrate the multiple databases that are involved in the research we do. In the middle, we've got a registry, which is all the residents of Manitoba. And then around the circle, we've got multiple ellipses, which represent databases. We currently have over 90 of these at the center. The ones in taupe are health databases. The ones in gray are social databases. And then we've indicated on the right-hand side of the slide, as you look at it, the specific databases that we've used for this study related to First Nations health and well-being. We're going to go back now to the next slide and talk a little bit about the context of this work. And Leona is going to talk a little bit about that within the context of the Truth and Reconciliation Commission.
So in terms of the 94 calls to action, this work, this partnership that we have with the Manitoba Centre for Health Policy really answers call to action number 19, because right now this currently does not exist. The last time we had a report like this was in 2002. Just to give you an idea in that context as to how big of a data gap we have when it comes to the health and well-being of First Nations people living within Manitoba. And not only Manitoba, but all across Canada. In terms of having access to timely information, in order to be able to close those gaps, we need information, we need accurate data, and we need partnerships like the one that we have with Manitoba Centre for Health Policy, which again is one of the most internationally renowned data repositories around the world. And for us to be able to partner based on an information sharing agreement that really governs our relationship and how we share information in order to publish reports like this one is the first of its kind, and the first time that that type of relationship has been, I guess, governed by an information sharing agreement that really supports the relationship. Next slide, please. So I talked a bit about when we had our first release of a report of this kind back in 2002, again with the Manitoba Centre for Health Policy. And since that time, we've had the calls to action that have been put in place by the TRC. We've also created a partnership with Manitoba Health Seniors and Active Living with the province of Manitoba to really develop community level indicators of health and well-being. So we used data linkages again through administrative health data to really showcase what the status of the health and well-being of First Nations were at the community level. So right now this report really focuses in on the regional area of Manitoba, focuses in on the RHA level, focuses in on the tribal council level, and also between the on and off reserve First Nations members, and really tries to showcase the gaps in terms of the healthcare utilization of First Nations people. One thing that's really unique about this report is the first time that the First Nations RHS survey has been brought in to link directly with administrative health data. Now, the First Nations Regional Health Survey is really about capturing strength-based indicators of health and well-being according to First Nations people. It's the only survey of its kind that nationally that has been designed, delivered, and implemented by First Nations since the 1990s. So one of the impacts of the First Nations RHS has been long-term investments from the federal government into suicide prevention, home and community care, Aboriginal Head Start programs, and diabetes initiatives. And based on the evidence that we provided through this partnership and through the publication of this report is really to inform those discussions moving forward towards a unified health system as defined by First Nations, because right now we don't have a health system that really works for First Nations. So this was one step in terms of really showcasing what those disparities actually are and where we could possibly fill gaps and address challenges within the healthcare system, and doing that based on information, based on data. And we work closely with our governance committee called HERC to identify key recommendations flowing from this report, as HERC had identified in the release of the 2002 report. That report did not provide recommendations, and they're pretty adamant in terms of our team being able to provide some solid recommendations for a pathway forward as described by, as highlighted within this report. Next slide. I'll hand it back over to Alan.
Thanks, Leona. So Leona's covered a lot of the details to be presented here in the methods section. I'm not going to spend a lot of time on this, other than to remind you that we're using mainly administrative data, and as Leona alluded to, the RHS for the first time. We do have something called a First Nations research file, which identifies people who are registered with Ottawa as First Nations. This is in itself a controversial list of those who are recognized by the federal government as being treaty people, although we're all treaty people as Canadians. However, that is the list that we are using in identifying First Nations. So we are comparing in this study First Nations versus all other Manitobans as a way of demonstrating the way our healthcare system is failing First Nations. We need some sort of comparator to indicate the problems that exist. And as Leona has also said, that we're comparing both by region in terms of regional health authority, but also by First Nations tribal council area. And we've also done some analyses by income quintile for all other Manitobans that is not included in the current analyses or presentation, should I say. So as we move on to the next slide, we'll see that the numbers involved in each of these, about 1.3 million Manitobans in 2016, of whom 142,000 almost are registered as status First Nations. Of those, 63% live on reserve, and 37%, almost 52,000 are off reserve. And of those off reserve people, 56% are in Winnipeg and 42% are in other areas of the province. So the comparison is between registered First Nations and all other Manitobans, who represent about 1.2 million people. Just at the bottom of each of those flows, you can see public health trustee. We have people who are registered as under the care of a public trustee in Manitoba. For those people, we don't have a postal code, and we do use postal code to identify where people are living. So people who are under the public trustee are excluded from our analyses by region. So moving on to the next slide, we'll talk a little bit about data governance, and I think Leona is going to speak to this again.
Thank you, Alan. Some of the key factors in terms of asserting First Nations data governance as it applies to data linkages is the principles of OCAP. in terms of ensuring First Nations have ownership, control, access, and possession of their own information, regardless of where it's held. And for that reason, this is why we entered into an information sharing agreement with Manitoba Centre for Health Policy to ensure that we had governance of First Nations information as it applies to the data linkages that we identified to effectively provide accurate information moving forward. One of the advantages of having data linkages or engaging in data linkages is to offset some of that burden of survey work in terms of collecting information. We know we have systems already in place as First Nations. We've always provided information readily, but we have not always been in a space where we're able to assert governance over that information. And utilizing the tool of OCAP to really assert that governance and to define what those parameters are of how information is used and managed and how that story is told and how that information is interpreted. That's really the essence of what OCAP is. It's really about a respectful research relationship from the onset right up to publication. And I'm really proud to say that this partnership and this research project has really adhered to those principles throughout. So I also like to acknowledge Alan and the rest of the team at MCH for really honoring that space and that relationship. And we know that it's hard to tell a certain story. It's hard to provide that evidence without many databases. However, one of the challenges with utilizing existing databases is that you're not the one defining those parameters in terms of how that information is collected or what information is collected. We've produced this report based on the most, the most timely and the most accurate way as possible that the public health system within Manitoba has the ability to be able to collect information. There's a bit more room for growth in terms of what type of information is collected in terms of those social determinants of health, because we're focusing strictly on administrative data. We've had support from the Regional Health Survey to provide a bit of context, but again, it's survey data. So until we actually start including some of the social determinants of health in terms of how we collect that information to answer some key questions and not just look at the surface level of outcomes, I think then we'll actually be able to really answer those calls to action in terms of showing those disparities and getting to the underlying root causes. I'll hand it back over to you, Alan.
Thanks, Leona. So the next three slides are just an overview of the big picture. And as you can see, it isn't pretty. So for First Nations boys, life expectancy at birth is 68 years, while all other Manitobans, it's 79 years, a gap of 11 years. For girls, it's also 11 years. So quite a dramatic difference in life expectancy, which is regarded as a key indicator of the health of a population. So moving on to the next slide, we get some explanation as to why that gap is widening. And Leona has alluded to the social determinants of health. And in this case, we're talking about the Indigenous social determinants. And I don't know if you want to talk to those a little bit, Leona, or?
I think in terms of the outcomes of colonization, the outcomes of racism within not only the healthcare system, but many other departments and within many other policies and laws, that really affect First Nations people and that have often been imposed, and poor housing, lack of clean water, poverty are a result of those impositions that have been created as a direct result of colonialism, as a direct result of, I guess, the Acts of Confederacy. The Acts of Confederacy was to effectively remove First Nations people from our lands and territories, to effectively remove us from our lands and the identities. And that has been supported through, I guess, the era of residential school, the era of the 60s scoop, and multiple laws that go on beyond that, and still in some cases continue to exist today until we actually shift and really address how we undertake those calls to action, how we create space to address racism and speak openly about racism, and to really challenge and acknowledge the true history of Canada and really the true history of our relationship between Indigenous people and non-Indigenous people. I don't think we'll, this is a start. This is a step forward.
So we move on to the next slide. The social determinants are crucial, but there are also healthcare system issues that need to be addressed. And the results that we now are going to show in a little bit more detail demonstrate some of those findings with regard to the healthcare system in particular. So the next slide shows some of our key findings in terms of health status. And this is a summary. The details are in a table in the slide to follow, but I've already alluded to the life expectancy gap. When we look at the 2002 atlas, we see that that gap is actually growing. It's getting worse. And then there's some specifics around things like cervical cancer screening and colorectal cancer rates. Cancer screening is generally lower with a significant gap. Substance use rates are 3 times higher in First Nations, and suicide attempts are 5 to 6 times higher in First Nations. A hugely concerning statistic that makes us wonder why that is and what we can do to correct that. So the next slide is an example of similar slides which you will see in the rest of the presentations. In the left-hand column, you'll see the indicators. So the first one is premature mortality rate, which means that the rate of per 1,000 of dying before age 70. Then you've got a wide column that represents the First Nations versus all other Manitobans comparison. And you can see that the numbers throughout those columns are all bold, which means that these are statistically significant differences. So when we do the analyses, the difference shown is not by chance. These are significant using statistical testing. And then the last 2 columns are a comparison between the on-reserve and off-reserve First Nations. Both of these 2 columns represent what we call adjusted rates, which means that we've adjusted them to accommodate the age differences, the age and sex differences, so that we can actually say that we're comparing apples to apples or pears to pears and not comparing different populations that are different significantly. I'm not going to read the numbers on the slide. They're there for you to see. And just to remind you that this report is available on our website with all of the graphs and tables there for you to see. So moving on to the next slide, just to re-emphasize the fact that fewer First Nations people receive Pap tests and the cervical cancer rates are higher. So this is a direct relationship that Pap tests are tests that are done to identify pre-cancer in women, which can result in treatment and preventing cervical cancer. And here's an example of the impacts of not doing those tests in women, as Indigenous women, as much as we should. First Nations women, I should say. And then the next slide talks about some of the other cancer screening tests that we did, that we looked at, mammography for breast cancer, and once again, significantly different rates between all First Nations and all other Manitobans, as demonstrated in bold. And the same applies to colorectal screening. Very low rates for colorectal screening, as demonstrated in the time period we were looking at. We believe that those rates have improved over time with the colorectal cancer screening program having been implemented since then. But once again, the actual incidence of those cancers is presented in the next three indicators below that. And interestingly enough, even though mammography rates are 20% difference between First Nations and all other Manitobans, the breast cancer actual rates are not that different. So that's the numbers per 100,000, not a rate, by the way, I'm sorry. So we need to ask the question why that is. And one of the things about doing the work that we do at the center, where we look at these high-level rates and incidences of events, they don't often tell us the reasons for those differences. Leona's spoken a little bit about some of the reasons that we know based on the social determinants, but here's an example of a difference in outcomes that we don't really understand. Even though the screening rates are low, are quite different, the actual rates of breast cancer are not that different. So moving on to the next slide, highlights something that I've already alluded to, is the 5 times greater suicide attempt rates among all First Nations. And the table that follows is about mental disorders in general. So we've got here, these are diagnoses of specific mental disorders. And for some of these, we need to recognize that when physicians make diagnoses of mental disorders, this is a judgment call. So while somebody might be diagnosed, somebody who's a First Nations person might be diagnosed with a drug and substance use disorder by a clinician who doesn't understand the reality of their life. Somebody who is not First Nations might be diagnosed with a mood and anxiety disorder as their diagnosis, even though they might be using substances to address those same challenges. So for some of these, the results are dramatically different. Hospitalization for suicide attempts, 24 per 10,000 for First Nations versus 4.2 for First Nation, for all other Manitobans. And the suicide rates, as I said, 5 times different. And lots of statistical difference, even though the numbers are both obviously different, but when we do the statistical difference, that's confirmed. These are things that are calls to action, in my view, for us as people who are involved in running our healthcare system, who are setting policies and providing services to First Nations with regard to these kinds of issues. The next slide presents the same kind of data a little differently. And it's presented here as much as to show you what the report looks like as for any other reason. These are presented by regional health authority. So this is about the drug and substance use disorder prevalence, which we saw in the previous slides, adjusted rates from age 10. And you can see here the graph, which is presented by Winnipeg, by health region, provincial health region. And the regions are listed in order of premature mortality rate, with the healthiest, the lowest premature mortality rate being at the top, being the Southern Health Region, and the Northern Health Region being the least healthy when using premature mortality rate as an indicator, and then Manitoba results being at the bottom. So one of the things that is obvious from this is the great dramatic differences between First Nations and all other Manitobans. And then you can also see that there's a number 5 after each of the regions, which indicates that each of these are statistically different from Manitoba. So when we move on to the next slide, we'll see the results from the RHS where, oops, no, that was the right, so you've gone 2 slides on, sorry. This is the lifetime substance use treatment that was self-reported from that survey. And you can see it's about 11% for First Nations self-report, which is not that different from the results we get when we use the administrative data in terms of how people are diagnosed. So moving on to the next slide now, we go on to mood and anxiety disorders, where those dramatic differences, where the differences are not quite that dramatic in terms of the percentage of individuals who were diagnosed with mood and anxiety disorders. And once again, if you advance, you'll see the results from the RHS survey, where, next slide, please. Thank you. Where self-reported diagnoses of lifetime mood and anxiety disorders are actually much lower than those that we find in the administrative claims data. So once again, this is a question. Why is there this dramatic difference? And how do we interpret this? And we can't necessarily answer this question in detail from the administrative claims data, other than to understand that culturally, First Nations people may have a different understanding of mood and anxiety disorders, and traditionally over many years have shown resilience in handling these kinds of what we will call mental health conditions that may not be even identified by people suffering from them within mental health, within First Nations culture. They might just see this as things that they overcome and deal with over their lifetimes, without necessarily diagnosing them as or feeling that they have a disease, as it were. Just to point out also that here there are different numbers in parentheses after the different regions, and at the bottom left you'll see the explanation for those numbers. And just to say that this is the way the results are presented in the written report, and when you read the report and you see a 3 and a 5 next to Prairie Mountain Health there, that shows that all First Nations are different to the Manitoba average, and all First Nations are different to all other Manitobans. So just to pay attention to that when you're looking at the results in the report and explain why you're seeing those kinds of things. So hospital services is demonstrated in the next slide. We go back to the table, which shows the indicators down the left-hand side again. Once again, the comparisons between all First Nations and all other Manitobans, all bolded numbers. So these are all significantly different and quite dramatically so, 3 to 4 times greater in hospital episodes per 1,000 people. That's single admissions to hospital. We then present hospital days, which is days spent in hospital, but 5 times different, I think it is. 3 times different. Hospitalizations for mental health conditions, once again. And I'll draw your attention to hospitalizations for ambulatory care sensitive conditions, because this is an indicator which is used to demonstrate an outcome related to primary care services in the community. So the idea is that if you achieve that you are provided with services that are high quality services, that you have good access to for certain conditions, you should avoid hospitalization when you get care in the community, so that care in the community deals with that condition and you won't need to be hospitalized. Here we see a 5 times difference between all First Nations and all other Manitobans, indicating that there's an issue here with regard to either access to care or access to quality care, or both. So this is an issue which we'll talk about a little bit more when we talk about visit rates, but something to bear in mind – that it's not just the, sorry, it's not just the, 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 it's not just the social determinants that have resulted in the poor health status of First Nations. It's about the care that we as healthcare providers and a system provide to First Nations that plays a role in these differences. So moving on to the next slide, we see the way these results with regard to ambulatory care sensitive conditions play out with regard to the tribal council areas. And this is just, once again, a way of showing you the way the report is provided, some of the results in the report. And if you look at the results in this one, it's kind of interesting because this is, there's no significant pattern here. The tribal councils are listed in order of their premature mortality rates. And what we're trying to do here is just demonstrate that it's not a simple thing to understand how those ambulatory care sensitive conditions play out in the different tribal council areas. So the next slide is about the hospital episode. We're not showing that one. So moving on to the key findings with regard to service use. There is a significant disparity in health status and use of physician services, as is indicated, the high rates of ambulatory care sensitive conditions and the discrepancies between hospital episodes. I just want to draw your attention to use of traditional healers, which is not something which we've got a particular graph or table on, but is included in the RHS and is useful for us to understand the use of services on reserve in particular by First Nations. So the next slide is a table. It looks at physician services and practitioner services. Next slide, please. And here we see a difference, a statistical difference on reserve versus off reserve First Nations with regard to ambulatory care visits. So something's different between what's happening on reserve and off reserve, with off reserve having higher rates, which means a less access to high quality care, and specialist visits being the same. Sorry, the specialist visits being the opposite. Here, ambulatory care visits is better, we think, to specialists, that there's access to the kinds of care that people may need for their health. I'm going to talk a little bit about the quality of care index, or the continuity of care index. So we know that when people get ongoing care from the same provider over time, that provider gets to know them better and is able to provide their needs in a better way. So that's called continuity of care. There's an index which measures that, which we calculate from the data. And you can see that all other Manitobans have a higher continuity of care index, which may explain to some extent some of the better outcomes that they have. But then this is a call to us to, in the system, try to provide better continuity of care for all First Nations. So the next slide is a graph. Moving on. The table with regard to drug dispensations. And this is the last section we're going to talk about, because it's a really important one that as we were doing this work, it became obvious to us that this is something that we need to address. And we can see here, in particular, with regard to the first three indicators here, benzodiazepine dispensations for community dwelling seniors, which is known to be something that the lower the rate, the better. And there's a statistical difference between First Nations and all other Manitobans. One of the Manitobans getting more prescriptions, though, and this makes us wonder why it is that In all other indicators, it appears that First Nations are not getting better care, but here they seem to be potentially getting better care. And is this about potential racism amongst providers? Opioid dispensations, 1 to 3 dispensations, are things that the opioid drugs are being dispensed from retail pharmacies. So we don't know when a prescription is written necessarily, but we know when a prescription is filled at a pharmacy. So these are prescriptions that are taken by individuals to pharmacies to get medication, and we think reflect to a large extent the prescriptions that are written by the providers. And you can see that the rates of opioid dispensations are much, much higher in First Nations. And while getting a prescription for an opioid when you have a broken leg or some other cause of severe pain is very appropriate, when you get more than 3 prescriptions over time, there's a question as to whether this is a problem, because when you're getting more than 3 prescriptions, the likelihood is that's going to lead to a potential addiction or dependence upon that medication. So we have only 1 minute left formally, but I know that Leona wants to talk a little bit more about the opioids. So I'm going to hand it back to her to talk more about that.
Thank you, Alan. So in terms of like some of the rates that we're seeing, especially around the Prairie Mountain Health, we had some of our communities within that region, especially amongst the Dakota Nations, that really raised the alarm bell well before our report. And the fact that we can see those rates really demonstrated within the analysis, it just really echoes those concerns and provides that really strong evidence that there, in terms of those opioid prescribing, are those areas that have higher rates of opioid prescriptions are really evident within the report, and really further supported by the alarm bells that were raised by communities. In terms of addressing some of these high rates, our research team at FNHSSM has partnered with the Public Agency of Canada through funding provided by Canada as well, is to really do an opioid and substance use specific report as it applies to First Nations. And really that report will be coming out later on this year, hopefully based on the various approvals that we need to go through, and just really providing that evidence for First Nations to address opioid use and misuse amongst First Nations, and really bring individuals collectively together to see where those rates are higher and why those rates are higher, and really bringing in those key stakeholders from the College of Physicians, from the College of Nursing, the College of Dentistry, to see how we can collectively work together to address these high rates, and also bringing in First Nations advisors and community members to really share their experiences and provide their recommendations on a pathway forward. Next slide, please. I know we only have like 1 more minute. I'm going to actually, as this presentation will be made available online to those participants, I'm going to move towards the recommendations flowing from this report. Can you move on? In terms of some of the recommendations that we provided following this analysis is, again, continuing to support the annual reporting of healthcare and well-being amongst First Nations. So really answering those calls to action, not just waiting another 10 years until our next report, or 20 plus years. So we want annual reports and progress, really evaluating how the province and the feds are actually working together with First Nations to create a a pathway to address these gaps in terms of addressing, focusing in on those intervention and prevention measures that need to be put in place that actually need to be supported by anti-racism initiatives that really call out racism for
And there are multiple other very detailed, specific things which we look at the slides and say, well, why is this different in the area? And what's in this area or this tribal council area? And why is this? And that's work that needs to be done, I would suggest, by the policy teams and the regions in terms of understanding why are we different in a particular region, and how can we then address that in a way that is respectful to the people living within our region. So this is really for me, a call to further work at the regional level that we at the centre could be involved with, but it's work that needs to happen to actually address the inequities that we've uncovered.
I think just one final comment from our organization is just, this is one report. It doesn't actually propose to answer all challenges that we see within our communities, and that